Here myself. So we're going to go ahead and get started. For those of you who don't know me, my name is Jason Nator. I'm a member of the Emerging Professionals Program Events Committee. And today I have the honor of introducing our guest speaker, Dr. Alona Balasanova. Dr. B is an associate professor at UNMC in the Department of Psychiatry and holds an appointment in the College of Allied Health Professionals, duly board certified in psychiatry and addiction medicine. She got her undergraduate degree from Johns Hopkins University and her MD from Harvard Med School, and completed residency training at Boston University Medical Center before coming here to Omaha and joining the UNMC faculty. As the Director of Education in Addiction Psychiatry, Dr. Balasanova has developed novel educational programs for medical students, residents, fellows, and allied health professionals. Dr. Balasanova was the founding director of the Outpatient Addiction Psychiatry Clinic and also developed and co-directs the inpatient, the Inpatient Addiction Psychiatry Consultation Liaison Service. That's a mouthful. Mm-hmm. She's presented nationally and internationally on addiction psychiatry education and destigmatizing substance use disorders. In recognition of this work, Dr. Balasanova has been awarded the American Medical Association Foundation Award for Health Residency Education in 2020, the APA Irma Bland Award for Residency Education in 2022, and the Nancy Rose, is that right, Award for Medical Student Education last year in 2023. And I say all this because it's true and not just because she's my wife. So I'm pleased to introduce Dr. Balasanova.
Thank you. Oh, this is definitely on. Hi, everyone. I'm so excited to be here. This is my favorite subject, stigma and language. So I get to talk about my favorite thing. I don't have any disclosures. So briefly, we're going to talk about the following things in these next 30 minutes. We'll define addiction and substance use disorder and review related terminology just so that we're all on the same page about what we're talking about. We'll discuss the impact of stigma specifically on substance use treatment, and we'll identify some interventions that can reduce stigma and provide evidence-based care. And these are things that really all of us can do. So addiction. We hear this term a lot, we hear it in the media, but what does it really mean? What is the actual definition? So it is a chronic brain disease that has the potential for remission and recurrence, right? So it's chronic. And it's associated with uncontrolled or compulsive use of one or more substances. It is also considered to be the most severe form of substance use disorder. So really the salient parts here are that it's chronic, right? It's not acute. You don't just get rid of it overnight. It's something that really lasts a long time, like diabetes, like high blood pressure, and it has the potential to recur, right? So you'll have symptoms, but then also a potential for remission for a very long time. You could have a substance use disorder that's in remission for 20 years. So that's something to bear in mind. The other important facet here is that it is uncontrolled use despite negative consequences. So many times people will wonder, well, how can they keep using substances or keep drinking alcohol? All of these bad stuff is happening to them. Well, they want to stop, they just can't because their brain simply won't let them. At this point, it has become an addiction and it has become uncontrolled despite their best efforts. So a severe substance use disorder, as I said, is called an addiction. And substance use disorder is defined by the Surgeon General as a medical illness that is caused by repeated misuse of a substance. So this also develops gradually over time and leads to brain changes. And so we mentioned substance misuse. Repeated substance misuse can result in a substance use disorder. So let's define that so that way we're all clear. So substance misuse is the use of a substance in any way that can cause harm to the individual or those around them. So the example I like to give is if you are 21 and older and choose to drink and you're out at dinner and you have a glass of wine, that is substance use, right? That is socially sanctioned, appropriate, nothing wrong with that. However, if you have too many glasses of wine and then get behind the wheel of a car, well, now that's become substance misuse, right? Because we're using alcohol in a way that is harmful, both to ourselves and to those around us if we're driving a vehicle intoxicated. So the brain changes I mentioned impact these three major areas. This is a really simplified picture of our brain. So our prefrontal cortex is the part that really separates us from our other mammalian counterparts. This is what allows us executive decision-making, planning our behaviors, inhibition of behaviors. We have the more primitive centers with the basal ganglia, and the extended amygdala is really our emotional center. So the brain changes that occur, again, chronically with chronic use, is that we have an impairment in our executive function. So this prefrontal cortex area is really impaired. The neuronal connections are in disarray, and that leads to problems with self-control, right, which is why it's uncontrolled use, and decision-making. So you're not making the best decisions despite your best efforts to, because your brain kind of won't allow it. And in effect, it's been hijacked by the addiction. So this is the continuum of the words that we've talked about. So substance use, which can lead to substance misuse, obviously doesn't have to, but it certainly can, which over time, repeated substance misuse can lead to a substance use disorder. And then the most severe substance use disorder is called an addiction. So perhaps more importantly than what addiction is, what is it not? It is not a moral failing. It is not a character deficit. It is not bad behavior. It is not poor decision-making, although that can be a symptom. And most of all, it is not a voluntary choice. I think that's the biggest one that folks tend to forget, because by the point that it's an addiction, you don't have a choice anymore. It's not like you're using substances recreationally at that point. It's uncontrolled, compulsive, and you can't stop despite your best efforts. So the language of addiction really matters, right? So language is really the fabric of our society, what weaves us all together. And the words that we choose when we talk about these folks really matters. So we want to be saying what is clinically accurate and non-stigmatizing: substance use disorder, substance misuse, substance use, addiction, a person with a substance use disorder, right? Person first language is really what connects us in our shared humanity. We're not labeling somebody as an addict or an alcoholic and taking away their humanity, right? They're a person first and foremost. Substance abuse, of course, really is a kind of a callback to criminal behavior, which of course is not what we're talking about when we're talking about a medical illness. And replacement therapy seems to suggest that taking medications for your substance use disorder replaces one addiction for another, which of course is not the case, because taking a medication treats the substance use disorder. And we'll get a little bit more into that coming up here. So what we don't think, we think, meaning that the impact of bias is universal. We are human, so we all have unconscious bias despite our best efforts. Every single one of us, doesn't matter how well educated you are, doesn't matter how well trained you are, this is universal. So there's several examples of bias that can happen in clinical practice simply by hearing these negative terms. So there was a study, this was out of Massachusetts General Hospital, looking at attitudes and clinical practices of the physicians who take care of hospitalized patients, who are hospitalized for pneumonia, broken leg, whatever it may be. And so they surveyed them on their thoughts about patients who have substance use disorders. And 38% of those surveyed thought that substance use disorder is somehow different than other chronic diseases, because people who use drugs or alcohol are making a choice, which of course we know it is not true that you are making that choice, because your brain's been hijacked by the point that it becomes an addiction. 14% felt that medication treatment using opioid agonists is replacing one addiction for another, which of course is what that replacement term, replacement therapy, seems to connote. And 12%, this is the most chilling in my opinion, thought that somebody using drugs is committing a crime and deserves to be punished. And I like to think of this as somebody with diabetes and obesity who is eating a piece of cake, right? Do they deserve to be punished? Are they committing a crime? Absolutely not. We would never think of it in those terms. And yet, when we think about substance use disorders, that's what immediately comes to mind, even for these super highly well-trained professionals. And these attitudes, right? This was a survey of their attitudes. These attitudes can actually impact patient care, which is the scariest part. So our attitudes and our implicit biases drive behavior. We know this to be true. So we know that clinicians are more likely to assign blame to patients and to agree with the need for punishment and view a substance abuser less deserving of care than somebody that is the same person described as a patient with a substance use disorder. And the way we know this is this was one of the sentinel studies that was done. This is a comparison of two vignettes. So these vignettes were provided to mental health clinicians at a conference. And one talks about Mr. Williams as a substance abuser. The other one talks about Mr. Williams as somebody with a substance use disorder. Everything else is held the same, right? And so those that had the substance use disorder were less likely to agree with the need for punishment or blame, right? We're less likely to think the person was not deserving of care. And those that read that it was a substance abuser thought all those things, right? Simply because of those terms, they just put you into this implicit negative headspace. And this can actually impact clinicians themselves as well. So in general, we know, I mean, society at large also, but healthcare professionals generally hold pretty negative attitudes about patients with substance use disorders. And these attitudes are linked to lower levels of empathy and engagement with these patients. So we're a little bit more detached as clinicians when it comes to working with this patient population. Well, burnout, I'm sure everybody's heard about, is like a huge thing in healthcare right now amongst all facets. And one of the hallmark signs of burnout is decreased empathy. So not only is this leading to poor outcomes for our patients, this is actually harming ourselves as clinicians. Those of us in clinical practice and those of us that work in the healthcare field, this actually impacts our own burnout as well. So it's something to think about. It's not just about the patient, but it's also about us. So stigma, this is the best graphic ever because it really is like this. Like it just keeps you back. It prevents you from moving forward. It keeps you stuck. And in part, it's because society has placed the stigma onto substance use disorders and the people who have them. So it really is comprised of three components. We have knowledge, so ignorance, attitudes, prejudice, and behaviors, discrimination. So those three components comprise stigma. And the National Academy of Medicine defines it specifically as the attitudes, beliefs, behaviors, and structures that interact at different levels of society, individuals, groups, organizations, systems, and manifest in prejudicial attitudes about and discriminatory practices against people, right? Any group of people. And so stigma against people with substance use disorders is pretty prevalent. In healthcare, misinformation and bias is a significant driver of negative health outcomes. There are clinicians who hold this view that somehow these patients are dangerous or too difficult to treat or too complicated and you just don't want to deal with it. I've literally heard people say, I don't want those people in my waiting room. Like I've heard people say that. And you have to wonder, like, don't you know they're already there? Because they are, you just don't know because you don't ask. But this is a major issue and it really transcends, right? It transcends just people with substance use disorders. There's a lot of intersectionality here. And it's important that we recognize the importance of culture and context and the experience of stigma and the mitigation of stigma for any group of people that we work with. So switching gears a little bit to bring into perspective just how common this is, right? We stigmatize it so much and yet it is so common, 1 in 7. So I always, whenever I'm giving a talk, I like to say, if we go around the room and count off by 7, statistically speaking, that is how many people would develop a substance use disorder at some point in their life. It is simply that prevalent. And this is looking at the provisional counts of drug overdose deaths, which, as I'm sure you've seen in the news, is a major issue. And it continues to be a major issue despite recent reductions in prescribing of opioids of upwards of 50%. So in the last 5 or 10 years, we've actually reduced our opioid prescribing as a nation by around 50%. And yet the overdose deaths are the highest they've ever been, and they continue to climb. So we know it's not just about preventing, right? Prevention with the opioids, but it's about treatment, right? We need to catch the ones that already have the problem, not just preventing those from getting a problem, which of course we should do, right? It's really a multi-pronged approach. And this was the 12-month provisional numbers looking at the drug class. So this is salient. In Nebraska, I will say methamphetamines are huge, much more common and much more frequently encountered than opioids, although there are far more opioids these days than there were when I first came in 2016. So that has changed. We have seen an influx of fentanyl as well, including in the methamphetamine supply. So we're having fentanyl contamination and all sorts of things. But the synthetic opioids, other than methadone, right? Because methadone is also a treatment for opioid use disorder, primarily fentanyl, carfentanil, some of the analogs that are being illicitly manufactured by drug cartels, often in Mexico, and smuggled across the border. That is really what is causing these overdose deaths because of the very high potency of fentanyl and its analogs. So while 1 in 7 will develop a substance use disorder, only 1 in 10 will actually get treatment, right? 10%. So 10% of people who need treatment for substance use disorder only get it, only 10%, right? So 90% don't get it. So I like to ask, how would we react if only 10% of people with cancer got treatment, right? It's not something that would be even fathomable to us, right? Like, how can that be when this is a major issue? And yet, society at large seems to kind of be okay with the status quo. And in large part, that's because of the way we historically looked at substance use treatment. So this is the traditional approach. And I love this cartoon. So we have Lucy offering, professional services, and we have Charlie Brown coming and saying, I have deep feelings of depression. So really sharing some intimate details and asking for help. Like, what can I do about this? Well, she tells him to snap out of it and pay her, right? So this is exactly how our treatment system historically has worked. We tell people to stop using and pay a whole bunch of money to go to a residential center. And then it's a revolving door. So then they actually end up spending so much money without the appropriate treatment that they need, right? So this traditional approach that we had was based on this historical idea that substance use disorder is acute and curable. And that we started off by defining it as a chronic disease because we know now that it's a chronic disease, and decades of research have shown that to us. Historically, that was not known. And the priority was always to remove access to the offending drug, whatever that may be. The services were time limited, so usually 28 days where you go in, live somewhere. And abstinence is the only goal, right? Like, it's abstinence or bust, there's no other option. And medications are verboten. I mean, that's not something that was even talked about and frankly didn't exist and still doesn't in many places. So this traditional approach really was what we now call residential treatment, or quote unquote rehab. So we know that if you go away for this 28 days and live somewhere else that is not your real life, 66% or more will actually return to use within weeks after leaving. And over 85% will return to use within a year, right? If they just do this residential program. And there was one study looking at patients with alcohol use disorder that actually found 92% return to use. So basically the entire thing was a giant waste of time. And oftentimes actually makes things worse because for those that use opioids, if there's no medication treatment offered, and what happens over those 28 days when you're not using is that you lose some of the tolerance that you've developed over time. And so when you leave and you obviously end up using again, if you go back to using the same amount that you used to use, you may accidentally overdose and die because you've now lost the tolerance to it, right? Because you've had this month-long abstinence. So it actually can be harmful in a way as well. And partly it's because, again, we've seen things differently, right? So hypertension, high blood pressure. So this is this was from the year 2000, actually, from JAMA, I believe. And it looks at the comparison and how we view what we consider a medical disease, and addiction treatment, which also is a medical disease. So hypertension, high blood pressure, before you get treatment, you have severe symptoms, right? Makes sense. Your symptoms are severe. You have headaches, maybe dizziness. You go see your provider and you get a medication for your high blood pressure, which lowers your blood pressure. And so you don't have the symptoms anymore, right? You don't have headaches or dizziness or what have you. Well, say you stop taking the medication, what's going to happen? Your blood pressure is going to go right back up again. Why wouldn't it? It's a chronic disease. That's how you've been treating it with this medication. Well, you stop it, it's going to go right back up again. Well, the exact same thing happens with substance use treatment. So before you have treatment, your symptoms are severe. Say you go away for this residential, and while you're there, things are great because you're away from your real life, in a confined, controlled setting. But then you get plopped back to exactly where you came from, And what's going to happen? The exact same thing, right? Your symptoms are going to return without ongoing treatment because it is a chronic disease. That's why people don't stop their blood pressure medicine. They're often advised not to because bad stuff can happen. And so the exact same thing would be true for addiction treatment. So it's important that we redefine the treatment paradigm. So here's another cartoon, and this one is in color because now we're with the times, right? We're in the 21st century. So we again have Lucy providing her professional services, and we have Snoopy coming by and setting up shop next door at a more cost-effective rate, right? 2 cents versus 5, and friendly advice. So really it seems to be a little bit more approachable, right? A little bit more meeting people where they're at, friendly versus super professional. And so what this is harm reduction. So this is a new paradigm. I say new because in the medical field, it's still relatively new, despite those of us in the addiction part of the medical field, it's been around forever and ever. But this is a conceptual and clinical framework that is aimed to decrease the negative consequences of substance use without necessarily reducing the consumption of substances themselves. Certainly it could, but that is not the goal. And now recall, the goal used to always be abstinence, right? Abstinence or bust. This flips that on its head, right? Here we're saying, we're not even going to talk about the using of the substances. We're going to address the harms. We're going to address, what it's doing to you and what it's doing to those around you. So it is an evidence-based public health approach. It is strengths-based, so it is not one size fits all. You meet the person where they're at and you stay with them. So recovery is not defined by abstinence. And there are no progressive steps to complete. Some people maybe have heard of 12-step programs where there's certain steps you have to complete. This is not like that. And it's not a circumscribed program, right? It's going to vary depending on the person and depending on their unique needs. So they're really personalized interventions. And there's a spectrum of strategies, which is what makes it so nice. It's not this cookie cutter, go away to residential and you'll be cured mentality, but it is really looking at that individual and what's going to be realistic for them. So safer drug use, right? We have the idea of syringe exchange, naloxone, right? To overdose, to reverse overdoses. Moderation management. So if you're in a controlled environment or on maintenance treatment with a medication, or abstinence is also potentially a goal, but only if that's the person's goal, right? We don't place that goal onto them. If that's what the person wants to work on, excellent, we will help support that. But that's never what we say is required to focus on harm reduction. And so again, this idea that the goals do not necessarily include reducing the consumption of substances is fairly radical. And it's radical in a lot of parts of society, including even in our politics. We recently had our syringe exchange bill in the legislature that was vetoed by the governor for this exact reason, right? Because of poor education and misunderstanding of what the goals of such a program actually are. Right? So we focus on functional impairment and not sobriety. And so evidence-based treatment can look a lot of different ways. It depends on the person. So it's a set of services that can include medication, psychotherapy or counseling, and other supportive services that are designed to really enable an individual to reduce or eliminate their substance use if that's what they want, to address associated physical and mental health problems, and ultimately to restore the person to maximum functional capacity. Like, I don't care if my patient is using substances, if they're a contributing member of society, if they're coming home to their family every night and putting their kids to bed, if they're doing everything they need to be doing to live their best life. Like, who am I to judge whether or not they're using a substance? I don't really care about that. I care about all those other things and about them being a productive member of society. So medications, just a note on this, medications are a really important part of treatment for some people, not for everybody, but for some people. And we do have approved medications for alcohol use disorder, for opioid use disorder, and for tobacco use disorder. And it has been shown to keep patients in treatment longer, which of course we know if you're in treatment, that means you're not dead. So that is always a positive in this world that I work in. So it really increases their chances of a long-term recovery, being continuously in treatment, which again is such a paradigm shift from this time-limited services that we used to think about with residential, which in many parts of the country, including here in Nebraska, is kind of still the prevailing mentality. So medications can save lives. So they did several studies. This one was actually Medicaid enrollees, so lower income individuals and those in disability in Massachusetts that were receiving abstinence-only opioid use disorder treatment versus partial agonist maintenance treatment with a medication called buprenorphine that we often use. And so what they found was those that had the abstinence-only treatment without medications actually had a 75% higher mortality than those that had the medications, in part because, again, of that decrease of tolerance, right? And the inevitable return to use, and then accidental overdose and death. Criminal justice outcomes. So using medications can actually help prevent reincarceration for folks that have been incarcerated before. Several studies have shown this. So individuals, this was on federal probation, who were receiving opioid antagonist treatment with a medication called naltrexone, had a 50% lower rate of reincarceration and 70% lower rate of illicit substance use compared to those who did not receive medication. And for those who had outpatient medication, they actually had between 17 and 27% lower odds of getting arrested since starting treatment, even if they had prior criminal justice involvement, which is typically the #1 predictor of future criminal justice involvement. So that's huge that it can even overcome that barrier. So a note on peer recovery supports. These are really popular in many parts of the country. It's super wild in Omaha. AA is like all the rage. So there's a lot of mutual aid meetings. Actually, yeah, I'll talk about that first. So community self-help groups. So AA and NA are traditionally the ones that go back forever and ever. We have a lot. It's a very AA-dominated city, Omaha is. We have over 200 groups all over the city at various times. The groups are different. So some may be more welcoming of people who use other substances than others. Some are purely alcohol. Some, and actually I would say most, are against medications because they consider that not to be abstinence, although there are some that do welcome that. And they have these 12 steps that you're supposed to complete to be, to effectively work their program. And so while these can be really helpful to a lot of people, some people swear by them, other people hate them. They're not formal treatment, right? Because this is mutual aid, peer support, which is, again, very important, but it is not formal treatment and does not replace working with a medical professional. So back to the peer recovery support. So while individuals in AA can be peer recovery supports, absolutely, there's also actually quasi-professional peer support workers. We actually have a few here in the PES, in the Psychiatric Emergency Services. So peer support workers are basically individuals with lived experience with mental illness and or substance use disorders, and they role model recovery for people. So they can provide support across the continuum of care. So they've not only talked the talk, they've actually walked the walk. They've actually been on that other side. So when they approach somebody, say in the emergency department, who is really struggling, who's down and out, they're able to actually empathize and say, I've been there, like, I get it. This is a scary time for you. Let me tell you about what happened to me, and then they can connect that way, which is a much less threatening way, I think, to connect for many people than if it were with a professional, right? So again, Snoopy versus Lucy. And they really meet people where they're at and can be unexpected settings like the emergency department. There's typically like a certification course. I actually think our DHHS might have one. I think it's like 6 weeks or something to get, to be a certified peer support worker. So it is something that we have here at Nebraska Medicine. So the healthcare system and societal impact, kind of to wrap up here. So when we approach things from a harm reduction lens, we actually save a whole bunch of money. So for every $1 spent, we save $4 in healthcare costs and $7 in criminal justice costs. That's a lot, right? That is a huge return on our investment. However, it requires putting in that $1, which is very challenging in states that do not allocate funding. I mean, our governor recently cut funding to behavioral health in the upcoming budget when this is not seen as a priority, right? And so even though we end up spending more money this way by not actually putting money forward, right, preventatively, this is what ends up happening. But we know this to be true. And so in the states that have spent more money on this, they end up saving more money. So the take-home points are that addiction is a highly treatable chronic medical illness, and that meeting patients where they are at can reduce harm, right? Harm reduction. And most importantly, that non-judgmental, clinically accurate language can combat healthcare stigma and societal stigma as well. And I am happy to answer any questions.
I have a question more for the pediatric population. So around the stigmatizing language. So just in my experience, my background's in peds, and you don't hear, oh, they're addicted to something, or they're misusing something. You don't hear that substance use disorder. It's kids are gonna be kids. And stigma's still there, but we're blaming the parents, right? Instead of the kid, right? And so I guess, are there resources or this type of approach towards pediatric treatment, towards recognizing this in pediatric population?
Yeah, no, that's an excellent question. So, kids are not little adults. They are definitely like a different species. So, and you have to approach it differently, exactly like you said. And so there's actually a lot of preventative efforts right now, even like in middle schools and high schools, people are going in and having these conversations because like you said, kids are going to be kids, and experimentation is not the same as a substance use disorder. But I will say we have an adolescent clinic, and there are plenty of adolescents with actual substance use disorders that developed as a result of too much experimentation, right? And so we want to just provide that education, right? That's going to be, and having these conversations early and often with children is really important. I'm a little terrified of this myself because I have 6-year-old twins. So I am like, when do I start having these conversations? I don't know. So, but yeah, it's definitely important. The preventative side of things is more important, and to make sure they're aware of the risks too of experimentation, because they're going to do it anyway, but they should know about the risks. Yes.
How common is it for an individual to seek medical help and then go to a peer support like AA or NA versus the commonality of individuals just going straight into a peer support AA and option?
Yeah, that's an excellent question. I don't know if there have been studies to look at what the rates are. I will say from my personal clinical experience, plenty of people go to a self-help group after seeking medical help, because maybe they don't know much about it. For example, maybe they're not very spiritual or religious, because AA and NA are both faith-based. But there are other groups, like Smart Recovery is one of them. There's others that maybe they've never heard about. So then when they go see their mental health professional, then they can learn about that and then maybe engage in that. And that's definitely happened with a lot of our patients. There's other patients that try the self-help and it's just not enough, right? It's just not enough for them, and they need that professional support, and then they'll come out and seek help medically. So it's both. Yep.
On where exactly the highest, I guess, I don't know if I'm saying it correctly, like the highest opioid misuse rate within Nebraska? Like, is it amongst the more dense areas like Omaha? Is it more in the more rural towns?
Yeah, that's an excellent question. So Nebraska is an interesting state, and we do not do a very good job of surveillance and of gathering data, and especially overdose data. So that would yield the most information, actually, if we knew what the death was attributable to. However, because we don't have a medical examiner system, we have a coroner system in our state, and the coroner is sometimes a county official. And it is up to them whether they want to do an autopsy, right? And so they may not want to do an autopsy because the family has requested that, everybody in town knows Johnny, and I don't want people to know that Johnny had a problem, right? And so then they won't do an autopsy. And so then we don't have those numbers, right? And so that's the major problem, is that we're actually not getting the data to know where it's worse. I mean, I will say in urban areas, it is often not, the rates are fairly high. That being said, I know in rural Nebraska, it's not all rosy, and that there are definitely problems there too. So, but we just don't know. We don't have the data.
I was curious about the harm reduction, which that was very interesting to hear. Like, you're not trying to have them stop, not be abstinent in their abuse or in their
Misuse.
misuse, thank you. So I'm curious, how many, if there are studies, do people that are in that type of program eventually just stop using, or do they live their life, the rest of their life using, but they're functional in society? Like, how do their families react to that? I mean, I feel like as a family member, again, this is probably just major judgment. I would still not be happy that my
Yeah.
significant other or whoever is still misusing a substance.
Totally agree with you there. So it's interesting, right? So you start off with the goal of just supporting the person no matter where they're at, whether it's to stop, whether it's not to stop, whatever. Ultimately, they do stop, right? Like because the whole point is that it's not a judgmental space. It's not somewhere where you're going to yell at them. Like I've literally seen that happen with clinicians. And so you're there for them. And once they develop a trusting relationship with you over time, you know, the more like seeds you plant with them, the more likely they are to actually take you up on some of those treatment offers. You know, so for example, a syringe exchange program, which literally the point is to reduce bloodborne illnesses, right? So you're not reusing syringes when you're using injection drugs. The individuals who use those programs are 5 times more likely to get treatment, right? Than those that don't use those. And those programs are not treatment, right? They're the public health measure. But because of that trusting relationship, because it's a non-judgmental space, I mean, if you think about it, when somebody tells you to do something, as just humans, we kind of want to do the opposite, right? Like just in general.
Don't
So
know what to do.
yeah, exactly, right? And so then when we're constantly telling patients, like, don't do this, don't use drugs, don't drink, blah, 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 they're like, whatever, you know, I'm going to do what I want to do. And so this allows them to still have autonomy over their decisions.
And are they actually using the substance in an environment that a doctor's watching?
Oh, no.
They're
Well,
just doing it how
well,
they normally.
yes, exactly. So what you're describing is something called a supervised injection site or supervised consumption site. Yes. So that is a thing, not in Nebraska, and probably not in a million years in Nebraska. We can't even get a syringe exchange. That'll never happen. But yeah, so in Vancouver, in Canada, it's huge. And I went to one in Vancouver to like observe and see what it was like. And they don't typically have doctors, but they have nurses and other healthcare professionals to help reverse an overdose. It should one occur, to help tend to any wound care that might be needed, that sort of thing. So that is a thing. And that is kind of the ultimate harm reduction. Actually, the super ultimate is prescribing medical grade heroin and medical grade fentanyl to people, which in Canada you can do. So that would be like the ultimate harm reduction, I would say. But we're talking like low level harm reduction, right? Like not forcing people to stop.
So are you working on goals like that? So bringing some more of those resources to Nebraska?
Syringe exchange, I mean, that bill was my bill. So I played a very large role in the amendment to that bill, but we're going to try it again, you know, and see what happens in the next legislative session. But we're one of like 4 states that doesn't have one, right? It's like us and like Mississippi and, you know, like North Dakota has one. Like, why don't we have one, you know?
What does the state say, or this, you know, why won't?
Well, if you read the governor's veto letter, which is available online, he likened it to giving drugs to kids. And he said, we're going to give drugs to kids, and I won't stand for that. So, which is just a gross misunderstanding, right? And a misinterpretation of what is actually going on, partly because of stigma.
First, I want to say I really appreciate you like spreading the knowledge about harm reduction and medication assisted treatment. Having worked in a community health center where, you know, it's hard to find practitioners that are willing and like able to go through the certification process to be able to prescribe and manage those the medication assisted treatment. But the demand is so huge. Like,
Yes.
as soon as you have somebody that has certification, patients want.
Yeah.
Many we can't get.
Yes.
So thank you for that. And also, I have a question. If you could think of one thing that Nebraska medicine could do to better serve patients with a substance use disorder.
Oh, that's a really good question. I have to think about that because we've already done so much, like so much. But first, actually, before I answer that, and that'll give me time to think, I want to say that you don't need a certification anymore for prescribing buprenorphine or Suboxone. So since December of 2022, you don't need a certification. And I still get people asking me like, oh, can you do it? Because I can. I'm like, no, you can. Like you can. Everybody can. So, oh, yep, and yep, as of December 2022. Now, what can Nebraska medicine do? I think continuing to educate about language and stigma, I do think we've come a long way, since I came and developed some of the substance use services we have, and we've really kind of infiltrated the hospital system. So there's like a best practice advisory for naloxone that we developed that automatically fires. So people get naloxone for overdose prevention if they're on an opioid, which is like huge. It was like in the World Herald, it was a big deal. Things like that we're doing, like we're actually like super progressive in that regard, which is really cool, I think. Having an addiction psychiatry consult service is also fairly progressive, and some of the things we've been able to do with that. But I think the language element is pretty big. That's certainly my area of interest and passion, because it's easy. It's easy to change how we talk if we just take the time and effort to do so. And I do think there's a lot of just misunderstanding and miseducation. If you trained and, it was called substance abuse, that's what you know, right? That's not your fault. That's just what you learned. But now we can teach you something different. But that takes time and effort and a willingness to learn. But yeah, that would be the big one, I think, language. Yep.
First, thank you so much. This was fabulous. The language and everything. I am from a small town, rural Nebraska, northeast Nebraska. What type of like harm reduction is accessible up in that area, and for these smaller communities like Omaha, you have so many more resources. So for folks back home, what are they able to do? Because I feel like substance misuse, specifically with alcohol, is like the norm where I'm from. So how do we break through that? What's available?
Yeah, that's an excellent question. So alcohol is the number one thing in Nebraska. I like to tell my students it's number 1, 2, and 3. After that, we maybe go to meth. But 1, 2, and 3 is alcohol, right? It's huge everywhere, rural, urban, everywhere. It doesn't matter. That's the number one thing we see in the hospital too, is individuals there for alcohol use and alcohol withdrawal. The problem that I hear about is, one, there's a lack of providers, period, right? Of any kind of provider, mental health, primary care, doesn't matter, right? There's a lack of providers. The providers that are there are typically more senior, right? They're not like new grads that maybe just trained recently that know some of this updated information. They're kind of on their way to retirement. And so the adage of, you can't teach an old dog new tricks kind of applies to some degree, because they're like, I'm about to retire, like I don't care, And so when our medical students are required to rotate in rural Nebraska, their family medicine rotations required to be in a rural site. And I hear from them their experiences, which are not great when it comes to substance use. And in some settings, the clinician tells them not to ask about it because they don't know what to do about it. So because if they know about it, they have to do something, and they don't know what to do, so they'd rather not know. So it's kind of like a don't ask, don't tell policy, which is a problem when we have very simple treatments like naltrexone, which is a medication that anybody can prescribe. It's not a controlled substance. And it's efficacious for a lot of people, that if only people would be willing to prescribe it, that could be one option, right? That could reduce their alcohol use at the very least. So it's not as great as it could be. But we also do have telehealth for here. So people in other parts of Nebraska can always do telehealth with us here. So we do telehealth both in our intensive outpatient program and outpatient as well, including prescription of medications.
So that prescription, what is that?
Naltrexone?
What does it do? Is it for alcohol use?
Yeah, so it's funny. Yes. Yes. Good. What does it do? Good question. What does it do? Yes. What does it do? So naltrexone is approved for alcohol and opioid use disorder. It's not used very much for opioid use disorder. So we really focus on it for alcohol use disorder. The way that it works in the brain is it reduces something that we call the salience of alcohol. So the way I like to describe it is, say like when you're feeling stressed out, your go-to thing is to have a drink, right? That might be your number 1. Your number 2 might be to turn on the TV. And number 3 might be to eat a sandwich, right? Like say that's the order. It rearranges the order of those things. So maybe first you'll watch TV and then you'll eat a sandwich, and only then would it occur to you to have a drink. Right? Like that's what it kind of does. So you can still drink, people still do. And I tell them that like off the bat, because not drinking is scary to a lot of people, right? The idea of abstinence is really terrifying. So when I tell them, yeah, you can drink, but you're going to drink a whole lot less than you used to. And that is the point. The point is to reduce the heavy drinking that causes damage, right? And causes bad stuff to happen. So that's how it works. It just reduces the desire, it reduces cravings. You kind of just don't feel like it anymore. Pretty cool.
amazing.
I know, I want to put in the water, right? Like for everyone. It's a good medicine.
I don't know, I think in social media more and more, I'm seeing it being trendy to be like sober or sober curious. You see a lot of.
Yeah, sober curious is
celebrities
like a thing, yeah.
Yeah, I'm being so curious for the, or you know, the dry January and
Yeah.
things like that. Do you think those trendy things, those concepts are helpful in any way to this movement and education? Or do you think
Yeah.
it's more just kind of a dumping, these are celebrities being
I think that any conversation is positive, right? Like any publicity is good publicity. So if this is like entering mainstream, like conversations about substance use, I think that's a positive because this used to be something that was swept under the rug entirely, right? So now that people are talking about it out in the open, I consider that to be a positive because that could be step one to having a conversation with a healthcare professional about it. Like, hey, I saw something on TikTok, like, you know, tell me what it actually is or whatever. I actually was reading in a journal literally yesterday, the Journal of the American Medical Association, patients are turning to TikTok for health advice, what practitioners should know. Literally, there's an article on this. Yeah, because people, yeah, like it's like a whole thing now that people are turning to, I'm not on TikTok. Yeah. Yeah. It's true.
I don't know, yeah, I just thought it was just trendy.
Are there any questions on Zoom? No? Okay. Is that what we're, okay? No, well, you guys can always contact me if you have any other, or find me on Twitter. I am on Twitter, not on TikTok, but I'm on Twitter, so.
All right, thank you all for coming. And for those of you who joined on Zoom, thank you as well. There will be a recording available. I think we'll send that out probably after the session. So thank you, Dr. Balasanova.
Thank you. They're off.